Okay, I chose to do my project on low risk chest pain pathway in New Zealand. So to start out, we'll go over some of the current numbers and pathway that chest pain patients are managed within the country. There's approximately 38,000 chest pain presentations in New Zealand from the ambulance sector alone, presumably more that are managed in primary care and or referred on to the hospital. According to the literature, less than half of these presentations end up being cardiac, and even fewer of these patients require any sort of inpatient treatment within the hospital. The Auckland DHB currently has some guidelines for primary care providers that essentially lays out how they can manage these patients within the community, provided they come in as low risk or certain intermediate risk patients who might be more suitable for community management. Anecdotally, though, and what we see within our ambulance practice, especially in the urban centers, is that the vast majority of these patients are referred to ED, where they then get the testing and referrals that they could possibly be getting in primary care. So this presents an interesting opportunity for paramedics, especially with an extended scope, as to how we might fit in within this pathway. There's possibly scope to manage these patients more effectively in the community, um, and some of the skills that paramedics have in terms of actually seeing people within their homes might be beneficial. But in order to make that happen, we actually have to change the pathway for patients and add a few additional tools. So what we've proposed in this paper looks like this lovely little algorithm here. Essentially, it starts with stratifying patients by risk, um, and we've chosen the heart score, which we'll go over in a bit more detail. Um, Provided that they're low risk, they then move on to the community management part of the pathway, where they get troponin testing on arrival or when the paramedic arrives, and 3 to 4 hours post symptoms onset. Um, there's the scope to actually monitor these patients sort of every hour, going for a face to face assessment or ringing back on the phone. Um, and there's also possibly scope for having things like telemedicine, where you can monitor people's ECGs or vital signs and things. And that essentially all feeds this heart score where you can reassess risk. If you stay low risk, the next part of the next part of the algorithm is to either follow up with your GP or be arranged directly by a paramedic to go have a cardiology outpatient assessment or possibly some other services. If your risk score changes, and that would possibly be because VCG changes or because you have a positive troponin level, you would then be assessed in hospital as per um, the normal pathway as it exists. So, what does the evidence actually say regarding the feasibility of this proposal um, and the effects it might have on patients? So, when deciding if patients can safely be managed in the community, one of the most important things to ask is regarding risk. Are patients who are left at home going to be at a higher risk of having some sort of cardiac event rather than if they went into the hospital? So this is where these risk stratification scores come in. There are a variety of them out there, and there's about five or so: the Timmy score, the Gray score, the Frisk score, the Heart score, to name a few, that look at a combination of risk factors, age, ECG, and things like that to come up with how likely a patient is to have a cardiac event within a certain set time frame. So most of these scores are developed for use in the inpatient setting, so patients who already have a diagnosed acute coronary syndrome or who have received some sort of treatment like CABG or PCI, and it's basically trying to stratify them in terms of providing future treatments for them, whether it be through blood thinners or having them kept in the hospital for longer, that sort of thing. The heart score is a bit unique in that it actually allows you to put patients into different cohorts, so low, medium, and high risk, with the low risk patients having a less than 1% chance of having a negative event due to a cardiac cause within about a week's worth of time. So that's really important for us when we're trying to figure out if patients are safe to stay at home. Obviously, it's impossible to get people down to 0% risk, but less than 1% risk of having an event is pretty good, especially compared to some of the other scores. Some of the other advantages to this score are that most of the components about the score are within our scope already. So you get a score from 0 to 2 in a variety of categories. So the first one's history. Does it sound like it could be cardiac? Age, obviously older patients would have a higher score. ECG changes, there's specific ECG criteria. So having just some kind of generalized flattening won't get you as many points as T-wave inversion, or ST elevation, obviously. And having risk factors as well is another reasonably easy thing to elicit from a patient. The only thing that would need to be added is a troponin score, and that's kind of the main thing that would need to get added to a paramedic scope of practice in order to make this into reality. And again, just to reiterate, the main benefit of this scoring system is that you can identify low-risk patients who don't necessarily have ACS, and identify them for being suitable for community management. So we talked a little bit about the troponin score, but there's some other aspects that might be involved in order to make this a reality. Troponin score is the gold standard for ruling in myocardial infarction. Currently, there are two methods that are used. You have point-of-care testing, so your iStat machines, things like that, something that can be carried around in a Jeep, let's say. Or you have standard troponin testing. The current state of the evidence is that the point-of-care is slightly inferior to standard troponin testing, but for our purposes, just kind of getting a binary, yes, it's raised, no, it's not raised, it might actually be suitable, given that we're also going to put in place a lot of safety nets and have a kind of low threshold for referring people to a primary care physician or to cardiology directly. Another alternative is to just have mobile testing services, which are already utilized, come do the troponin testing, and that way you can have that laboratory gold standard test if you're worried about the evidence. But as the technology improves, this should become less of an issue in the future. The other aspect that could possibly be a logistical challenge is actually monitoring of the patients at home. There's no good literature about what a good sort of time frame is for assessing patients, whether it be every 15 minutes, every hour, every half hour. I mean, if you're in hospital in a monitoring bed, you're going to be receiving frequent observations, but the question isn't whether or not that's appropriate. It's whether or not the low-risk patients who are taking up those beds actually need those particular observations. So again, you can have safety netting in place, you can have a paramedic coming by, you can have telemetry monitoring patients, you can have phone calls back to the patient to make sure. But something might need to be put in place in order to make this a reality. And lastly, some referral networks need to be set up. So if you do get a positive troponin testing, I mean, that means you go straight to the hospital. That's an easy one. But if you don't, and you might still have a suspicion that the symptoms could be cardiac, you might want to send them on to a cardiologist for exercise stress testing, or involve other services or the patient's general practitioner. So some of these details would need to be worked out, but it's certainly not insurmountable. But it definitely would require a shift from the current inpatient model of care. It's effective to treat people in hospital in terms of safety and things like that for the most part, but it's not necessarily economically feasible, and it's not necessarily the best thing for the patient. One of the things that we're going to really need to discuss, and it goes back to that risk stratification, is what level of risk are we comfortable with, um, in terms of leaving people at home and treating them in the community. Even if the risk is less than 1%, that they'll have some sort of cardiac event in the time that we leave them at home, over, 38,000 people, that's still a reasonable amount of people who will have events. And it's very difficult as a young profession like paramedicine is to take responsibility for that risk when it's quite easy to say, well, why wasn't this patient taken to hospital? So there's going to need to be some really explicit discussions about what's an acceptable level of risk to leave somebody at home. Um, and it's going to require the upscaling on our part and the availability of some of these tools like point of care troponin testing. That said, there are some potential benefits to implementing this model over and above simply having less people in hospital. There are patients in rural communities or other hard to reach sort of areas or have socioeconomic circumstances that prevent them from presenting to clinics in the first place. So this has a potential to directly impact their health and well-being. We also have the opportunity to assess patients in their own home and get a better idea of some of the risk factors for cardiac events, whether or not patients are taking medications, some of the other socio aspects of health in terms of if they have enough food around, if they have enough care and help, and things like that. So it is a unique opportunity that has the potential to positively benefit people, but it is certainly going to require some change.